So I'm specialized both in nuclear medicine and endocrinology. So I will present how radioactive iodine interacts with the eye disease development of progression. So we'll start with a very short review of the eye disease. Clinically, it occurs in 20% of patients. However, if one will do the cross-sectional imaging modalities, such as CT scan, orbital CT scan, or MRI, or study the orbit with orbital ultrasound, it is noticed that Graves' ophthalmopathy is present in more than 60% of patients with mild involvement of the retroorbital soft tissues. There is also, very rarely, eye disease can occur with normal thyroid hormone levels. So euthyroid means normal thyroid hormone levels. So although the ophthalmopathy and the Graves' disease is present in the background, the thyroid hormone levels rarely can be within normal limits without the biochemical evidence of hyperthyroidism. The severe forms of ophthalmopathy occur in 3 to 5% of cases, and mostly in patients who smoke, in patients that have diabetes mellitus, also in men. The disease tends to be more severe compared to women, and also in older patients. The incidence of eye disease, 16 cases per 100,000 patients a year, and for men it's rare. The incidence is rarer compared to women, but the manifestation sometimes is more severe. And what's important to note is that compared to the historical controls, the eye disease today appears in less severe forms because of earlier detection and treatment. So the natural course of eye disease is variable and characterized by flares up and remissions. Spontaneous improvement occurs in 64% of cases after a natural course of disease to 2 to 3 years, as Dr. Smith mentioned. Stable eye disease in 22% of cases. However, unfortunately, in 14% of cases, the eye disease takes a severe course with progressive deterioration. And what we have learned in the past 25 years is that smoking indeed has a very profound negative influence on the progression of eye disease, both with increase in proptosis and diplopia, with significant increases, 3-fold, 2.5-fold increases. So also it appears that a patient who smokes also, the protective effects of steroids and orbital external beam radiation therapy is impaired. So that's why, as Dr. Smith mentioned, it's the best thing that one can do is to stop smoking, if they have that at the baseline. And it's the mechanism through which smoking impairs the response to steroids and also impairs this overall prognosis. It appears that there are several theories, but all converge on one important mechanism of tissue-induced hypoxia, so lower level of oxygenation at the level of the tissue in the whole body, but regarding the eye disease, it impairs the oxygenation of orbital tissues. So this is actually just an example of how progression of eye disease over 1 year in a patient who smokes. So it's very obvious, both clinically and by ocular measurements. Now, regarding what we can do to minimize the progression of eye disease, the most important step is actually to address the thyroid condition, to normalize the thyroid hormone levels. So regarding the therapeutic interventions regarding normalization of thyroid hormone levels, practically there are 3 major categories. One are the medications that block the thyroid hormone synthesis, and these are the methimazole or propylthiouracil. There is the surgical option of removing the thyroid and the entire reservoir of thyroid hormone. And then the third option is the radioactive iodine treatment to ablate the thyroid gland. So looking at this intervention, it appears that the anti-thyroid drugs, methimazole, tapazole, it's actually the representative of this class, does not affect the course of ophthalmopathy, the eye disease. However, the medication offers many times an imperfect control of thyroid function with multiple need for multiple readjustment And also the patients can be overtreated, so they become hypothyroid. The medication has to be decreased. So practically treatment, long-term treatment with medication requires very intense surveillance and multiple adjustments. And what's most important is the medications do not offer permanent control of thyroid disease and also eye disease. As the patient stops the medication, the hyperthyroidism relapses practically in 63 to 70% of patients when the medication is stopped. So practically the medications are used as a temporary bridge until a definitive decision for definitive treatment is taken. Regarding the total thyroidectomy or subtotal thyroidectomy, it has been shown that it has no relevant role in eye disease progression. However, there are risks of surgical complications, which of course are minimized with a specialized endocrine surgery team. So the risks are lower in specialized centers, and Dr. Miller will address all the details regarding this. So regarding radioactive iodine treatment, there is a concern that there may be a worsening of eye disease after radioactive iodine administration due to increased release of thyroid antigen from the thyroid gland and a flare of autoimmune response. And in this regard, this is the most important study that has brought the relationship between the radioactive iodine worsening eye disease to public attention, published 22 years ago, is the paper by Thalstedt in New England Journal of Medicine, in which he randomized patients to two groups and then prospectively followed them over a 2-year period of time, looking at the therapeutic interventions for thyroid disease and what is effect on these interventions on eye disease. So practically the first group, 54 patients, were treated either with medical treatment, which is methimazole and supplementation with thyroid hormone, or the second part of the group, the first group, is surgery, subtotal thyroidectomy. In second group, 114 patients were randomized either to medical treatment with methimazole, to surgery, subtotal thyroidectomy, or to radioactive iodine treatment, delivering 120 gray to thyroid. And unfortunately, in this group, 18%, so almost half of the patients, the hyperthyroidism has not been controlled with the first radioactive iodine treatment, and they require a second treatment of radiation. So looking at this, looking at the baseline eye status in these patients, 13% had eye disease at randomization, 13% developed eye disease in follow-up, and 5% had worsening progression of eye disease. And looking at the results, what is the effect of therapeutic interventions of eye disease? So regarding the medication, so treatment with anti-thyroid drugs, so worsening eye disease occurs in between 10 to 15%. With surgical treatment, eye disease develops or worsens between 11 to 16%. However, with radioactive iodine, there is this noticed significant increase in eye disease progression to 33%. And this is very nicely summarized in this graph, looking at the probability of development or worsening of eye disease with different therapeutic modalities. So practically, radioactive iodine is up here, showing that there is indeed an increased risk of progression after radioactive iodine as compared to surgery or medical therapy. Now, this study actually was the waking call, and then there are several studies that followed this in order to look at this relationship and what can be done about it. So the next experience by the Italian group, published in 1998, also in New England Journal of Medicine, followed a large cohort of patients with Graves' disease and either no eye disease at presentation or very mild. So 443 patients. So unfortunately, in this cohort, 55% of patients were smokers. So smoking history, and this is it shows that the study was performed in Europe. There is a huge difference in prevalence of smoking between European countries and North America. So practically in Europe, the incidence of the prevalence of smoking is much higher, 55% compared to 10% in America. So that's why the conclusions of that study have to be interpreted in the in the view of this additional factor for progression of eye disease. So all these 443 patients were studied regarding therapeutic modalities. So 150 patients were treated with radioactive iodine, 145 were treated with radioactive iodine and prednisone, and then 148 patients were treated with medical therapy alone. So, and then the patients were followed for 1 year after treatment with eye examination every 1 to 2 months by an examiner who was blinded to the type of the therapeutic intervention. And these are the results. So regarding the development or progression of eye disease, in the radioactive iodine treatment group alone, 15% of patients had progression of eye disease, which occurred in the first 6 months of treatment. And most of these patients had a pre-existing eye disease and smoking history. There is a transient worsening only in 65% of patients. So out of this 15% group, 65% of them had a transient worsening followed by remission. However, in 35% there was a progression of deterioration. Looking at the group that was treated with radioactive iodine and prednisone, the result showed a regression of eye disease in 67% of patients with mild eye disease at baseline, or no eye changes in patients who did not have eye disease. So that's a very important study showing the protective effects of prednisone therapy when administered with radioactive iodine treatment. And regarding the methimazole group, so the medical therapy alone, 4% of patients had improved eye disease, 3% had worsening eye disease, and 93% had no change in eye status. So this is consistent with the lack of effect of medical treatment on eye disease. So these 4% and 3% represent only baseline variation in autoimmunity process. Most patients did not have neither progression or regression of eye disease. So the American experience, this is a study published by Dr. Sisson here at the University of Michigan. He was my mentor, so I was trained by him. So he, and in collaboration with colleagues at Kellogg Eye Center, they studied a group of 76 patients treated with radioactive iodine. Here in America, only 10% of the cohort had a history of smoking history. The patients were followed for 1 year after treatment with eye examination by assessment of clinical activity scores performed at baseline at 2 months, 6 months, and 12 months. Patients also completed a quality of life questionnaire at baseline. And the definition of worsening of eye disease was based on a very objective assessment of clinical activity score increases at least by 2 points or more. 21% of patients had exophthalmos at baseline, and 10% of them developed new progression of eye disease at 1 year. And these are the results. Practically, there were some changes. 39% of patients had an increase in proptosis by 2 millimeters or more at 1 year. However, the changes were modest, with an increase of only 2.6 millimeters, a mean increase. 13% of patients had actually a decrease in proptosis by 2 millimeters or more at 1 year. The largest decrease was 6 millimeters. And this is mostly attributed to the stability, to the normalization of thyroid hormone levels. So the therapeutic effect of radioactive iodine in eliminating the hyperthyroidism. With all these changes, the changes were so mild that no patient required orbital therapy. And the most important factor that contributed to progression of eye disease was actually uncontrolled prolonged hyperthyroidism. So practically a failure of the radioactive iodine treatment to achieve prompt correction of hyperthyroidism. And it's well recognized that the need to repeat radioactive iodine, that means that hyperthyroidism persists and needs multiple treatments, that's a recognized variable that indicates increased risk of progression. So that's why in our clinic, our aim is to adjust the radioactive iodine therapy dose to achieve control and definitive treatment of hyperthyroidism within 3 months. So another study that puts all this data together, the United Kingdom prospective study on the effect of radioactive iodine therapy in patients with minimally active Graves' eye disease. The conclusion of the study was that the radioactive iodine was not associated with deterioration of eye disease in patients with minimally active eye disease when post-radioiodine hypothyroidism is prevented. So that's another important point, is that once the radioactive iodine therapy is given, the patients have to be followed very carefully with an examination at 2 months to 3 months in order to detect hypothyroidism and provide thyroid hormone supplementation in a prompt manner so that the normal thyroid hormone levels are achieved. So to summarize all this data together, is that eye disease worsens in 15 to 20% of patients who had pre-existing eye disease before radioactive iodine treatment. This is related to the release of thyroid antigens after radiation injury. There is a flare-up of autoimmunity with an increase of antibody against TSH receptor, which has been documented to last more than 1 year. And also, there is activation of the immune system with activation of peripheral lymphocytes, T cells, that actually migrate and concentrate in the orbit. The most important risk factors for progression of eye disease after radioactive iodine treatment is smoking. It's high levels of T3. So T3 is the more active form of thyroid hormone. And this is actually a marker of very severe or more severe thyroid hyperthyroidism and thyroid autoimmunity. High serum TSH levels, that means that uncorrected hypothyroidism after the treatment with radioactive iodine. Pre-existing significant eye disease and high thyroid receptor antibody levels, which are a marker of thyroid autoimmunity. So practically, it's very important when one chooses the modality of treatment is to look at the eye disease condition, and patients with severe eye disease practically we suggest that they may benefit from another definitive therapeutic modality such as surgery. So a very important factor in achieving successful treatment without increased risk of complications is actually proper selection of patients. So in patients that have severe eye disease, we practically refer them to surgery instead of treating them with radioactive iodine. So when we examine the patients in the clinic, we do an assessment of eye status, and if they don't have eye disease at presentation of very mild eye disease, then we can proceed with radioactive iodine treatment. It has been shown that in medium and high-risk patients, administration of a 3-course of oral prednisone prevents radioactive iodine-associated progression of eye disease. So there are two modalities in avoiding complications after radioactive iodine treatment. One is proper selection of treatment, of patients for this treatment. So you will select patients without eye disease or with very mild eye disease at presentation. And also we can administer prednisone therapy in order to mitigate the effect in the flare-up of autoimmunity, which can lead to Graves' eye disease exacerbation. Finally, so the treatment with radioactive iodine is more likely to induce progression if the patient has pre-existing eye disease rather than causing de novo or new onset eye disease. Progression of eye disease can effectively be prevented by oral glucocorticoid prophylaxis, and this is prednisone treatment. And if the patient does not have eye disease, or the eye disease is inactive, then the prednisone treatment is not necessary. So that concludes my presentation, and I will take questions. Thank you.